Good day. My name is Hyla Kluyts. I'm a specialist anaesthesiologist based in Garonkua near Pretoria in the Gauteng province of South Africa. Thank you for this opportunity to talk on perspectives on guideline development, implementation and evaluation in resource-restricted settings in the session on guideline development in anaesthesia. So in this talk, I hope to share some insight on the topic based on my experience as an active member of our national society, but mostly experience gained through participation in the projects related to the African Surgical Outcome Study brand under the remarkable leadership of Bruce Picard. And as a founder and director of Safe Surgery SA, the non-profit company that provided research support to these projects and administers the African Perioperative Research Group. I would like to acknowledge the dedication of the thousands of colleagues across the continent that continue to participate in APOC-driven projects. Key points that I want to get across in this talk are that guideline implementation are hindered by lack of education and training in low-resource settings. And resources to develop trustworthy guidelines are not available at local or national level in low-resource settings. So broadening clinical community participation may be key to developing, implementing and evaluating guidelines. Apart from the Seychelles and Mauritius, the whole of the African continent consists of countries classified as low and middle income countries. The majority of sub-Saharan Africa suffer from a critically low density of surgical workforce, as displayed on this World Federation of Societies of Anaesthesiologists workforce map. Those countries indicated in red have less than one physician anesthesia provider available per 100,000 of the population. In addition, inequality is endemic to our part of the world. Indicators of inequality such as the Gini coefficient indicates that South Africa on this map is the only country in the world with a Gini index of more than 60, and that for a number of sub-Saharan countries, the Gini index as a measure of inequality is on the higher side. And this background is important to support statements such as this eloquent observation by esteemed colleagues in a paper on the way towards high-quality perioperative care. Although evidence-based medicine is core to perioperative practice, building evidence is of limited use if there is no plan for how best practice can be delivered equitably. And I go on in this paper to propose 3 broad phases in the perioperative pathway where failure to deliver safe care results in avoidable death. And successful guideline implementation may impact most on the delivery of surgery and anesthesia, where it can support a patient safety culture and adherence to protocols, provided that providers are appropriately trained. So local practices may be improved with efficient dissemination of information or education, training in the implementation and use of guidelines, demonstrating impact at the call phase, and of course post-implementation support. And to reinforce the point of importance of education and training in guideline implementation, I would like to share the results of this study, where training on implementation of the essential steps in management of obstetrics emergencies reduced maternal mortality significantly. It is probably unrealistic to expect that resources can be found in low and middle income countries to develop trustworthy guidelines according to standards set in high income countries such as these by the Institute of Medicine in the US, even if the issues to be addressed may seem simple. But I believe collaboratively, colleagues working in low-resource settings may be able to make headway in prioritizing guideline topics. And indeed, establishing evidence-based practice guidelines is one of the top 10 research priorities of the APOC group. Note, however, that the development of training standards for perioperative healthcare providers number one on the research priority list should go hand in hand with guideline development. We know that patients in the African surgical outcome studies most often died from infective and bleeding complications. Practice guidelines to address these clinical topics are crucial, but it's also important to generate evidence on minimum requirements across settings for guideline implementation. The impact of training on implementation and adherence, other barriers to guideline implementation, and evaluation of a guideline in the context of a low resource setting. As I mentioned, I believe that these objectives can only be collaboratively achieved, and broad community involvement is important and translates to ownership, educational value, and success in the implementation of guidelines with improving outcomes. I'd like to propose an alternative application of principles of two concepts considered in other areas usually, which are asset-based community development and citizen science. With regards to asset-based community development, these principles can be applied in a clinical perioperative community where each person in the community has something to contribute. People are connected in order to sustain the community development. Citizens or members of the community are actors and not recipients in the development. Development is strongest when it involves a broad base of community action. Notions of apathy are challenged by listening to people's interests. And I think this is very important in the demoralizing environment of low resource settings. Decisions should come from conversations where people are heard. Asking for ideas is more sustainable than giving solutions. And local community members are in control of development. So I believe that the APOC collaborative can lead clinical community development in African low resource settings. An important exercise in asset-based community development is asset mapping, and we can specifically look at digital health opportunities, open science principles, developing assets, advocacy skills through our common goals and interest, and harnessing support from the global community. I don't think that there is any doubt that we will look back at the time of the COVID-19 pandemic and recognize the advancement of the fourth industrial revolution during this period. Practically speaking, the opportunities created by technological advancements can assist us in broadcasting information, networking, virtualization of education and training, electronic data capture, telemedicine, for example, a buddy system, and a lot of other opportunities that can be realized. So based on the result of a study conducted by a colleague at our institution, I believe that the APOC network is ready to make use of technological advantages. And in this study, which was a survey on mobile phone use for data capturing, quite a large number of participants from low-income countries participated. And the survey included a number of questions on, for example, Wi-Fi availability, interruptions in Wi-Fi, mobile network connections. But importantly, an observation was that the significantly larger proportion of participants from low-income countries were willing to use their own data to capture data for research purposes, their own resources, as compared to participants in upper and middle income countries. Open science, by developing open science as a community asset and using the open science principles to promote responsible research as a community endeavor, members can benefit through activities such as resource sharing, awareness of sharing opportunities, linkages between resources, and advocacy for removal of financial barriers or just distribution of resources, amongst other things. But lastly, I would like to briefly mention citizen science as an opportunity to generate evidence. The ability of the APOC network to deliver in the African Surgical Outcome Study may already have demonstrated the value of applying citizen science principles, as mentioned by colleagues in an editorial of the publication of the ASOS Risk Calculator paper. And I quote, "The unpaid contribution of more than 1,000 healthcare professionals working in very challenging conditions in the spirit of citizen science. Future collaborative projects where citizen science define the problem, perform data collection and analyze the results as suggested in this talk may then manifest at the highest level of extreme citizen science." Thank you.